Hello, this is me, Annette, from Harmonious Birth Doula Services. And today we're going to talk about just normal physiological birth. What happens? What is a pelvis? What happens to the baby in the process of getting from the womb to the outside world? So here's my little dude, and I have a pelvis. And we're going to also maybe speak about some normal variations because sometimes stuff happens that we can control, some things we cannot control. Yeah, we'll just see what that is and what's smart to do when you happen to be in that situation. Perfect. So today we're not going to talk so much about pregnancy and what happens. But what we know is that your hormone level of different hormones, they rise during pregnancy, especially the hormone of oxytocin. And we don't know exactly what happens when their body and the baby is ready to be birthed and labor is starting. We just don't really know, but I think there is different things happening at the same time at the perfect time, and that happens to start spontaneous labor. So one of the things is during pregnancy there are like hormone receptors being put on the uterus to be able to receive the hormone of oxytocin, because the hormone of oxytocin is also the hormone that creates the contractions. So one of the things they say is that when the uterine wall is filled with the receptors for oxytocin, it's also one of the things starting the labor. So in the beginning you could have small contractions. You don't really know if it's contractions or not. Your water can break at home at everything all at once, or just maybe there's a small leak from the amniotic fluid and it's coming a little by little. And this small things will create small contractions. Maybe you know you're in labor, maybe not. You're just hanging around. But when after a while the contractions will come in a more steady and rhythm most of the time, and you will not be in doubt if you're in labor or not. And one of these things is that you have your baby, and it's maybe with the back towards the left side or the right side most of the time. Some babies are like this, with the back towards your back. Some babies are more like this. Some are like this, and some are like this. Some are like this. Not so many, fortunately. And some are like this, with their legs up like this, like in a breech position. And some have their legs like folded together like this, or they have the legs down. Most likely your baby is with head down, in vertex, head down, back to the left, and the head is slightly flexed, and it's ready to be shot out from the uterus. And it's not going such a long way, really. It's like this little, but it takes some time. And some babies are high up in the womb, and some babies are engaged, or they're partly engaged down in the pelvis. And we have the pelvis here. Let me just adjust this so you can see a little bit better. Okay. So here we have the pelvis. And during your, this is the sacrum, which is behind here on your back. And this is the tailbone, the coccyx, which is down here. And then there's the hip bones here. And then you have the symphysis, which is in the front here. And this is the pelvic inlet, just like an oval, really. And the pelvic outlet is here. That's also an oval, but it's like in the other direction. So I'll tell you more about why this is, or very good later. So this is the passage the baby is passing through when going out the birth canal. And let's say we have the baby here with the back to the left, and it's a very small baby, maybe a premature baby, but and some babies are high up in the womb, and when the contractions start, they get pushed further into the pelvis. And some babies, they're a little bit down into the pelvis, but you can still feel some of the head over the pelvis. That's partly engaged. And then when the baby's like all in here, you can just feel the neck. You can't feel anything when you palpate the uterus. You can't feel the head at all. We call the baby engaged. So then you will be all the way here. So down here you have the cervix. So the baby is in the pelvis and the cervix is still holding the baby in here. When labor starts there, like the uterus starts contracting the baby down into the pelvis. And the uterus works, the contractions don't work like this, like just squeezing the baby. The contractions, they sort of work from up, and it builds up here and then pushes the baby down. So the walls of the uterus on the side, they're quite thin. And for every contraction, the top of the uterus, which we call the fundus, builds up and gets thicker. And during the birth, it gets thicker and thicker and thicker. And in the end, like all the muscle fibers have sort of got together up on the top to be ready to push the baby out from the pelvis. And this also happens because the cervix, while the baby is going through the pelvis, the cervix is opening, not opening like this opening, but sort of like if you have like this, like a tube, and it opens by little, like thinning itself upwards. So it's like this in the beginning, and it's like for every contraction, it's like thins, and then you have this opening here, like a bowl. And this side, the uterus, the sides of the cervix and the uterus sort of merge now and are quite thin, while the top of the uterus are thick and ready to push like the baby out with lots of power. So in the pelvis there are two bone structures. You can see them here. We call them the ischial spines. And when the baby who's up here, let's say it's partly engaged when labor starts. And then, which is sort of smart because the pelvic inlet is an oval and it fits the baby's head, which is an oval this way. So sort of fits like a key in the lock this way. So the baby's head goes in and there are contractions pushing the baby. The baby slowly descends and goes further down while rotating. Down, down. And we say when the head is like here at the ischial spines. Do you see them? Then the shoulders, which is an oval the other direction, fits in the pelvic inlet, because when the baby was up here, they didn't fit. They stopped the baby here, but the baby rotates, comes down to the pelvic inlet, and and down to the ischial spines, and we call this the baby's on the pelvic floor. And when the baby's all the way here, the cervical dilation is about like full open, like 10 centimeters. Sometimes 7, 8, 9, 10. And it takes some time because sometimes the cervix is not completely ready. I mean, it's open, but maybe if the baby needs one more small rotation, it can take some time here before it's completely ready for the baby to be born and for the mother to go into the next phase of the pushing the baby out phase of the labor. So also when the baby's head is down here by the ischial spines, it sort of touches the pudendal nerve, which comes on the inside here. When the baby's head gets in contact with the pudendal nerve, it triggers the fetal ejection reflex, which is like the contractions that pushes the baby out. So you have been in transition and it's quite intense. You're breathing and you get all the way to here, to 10 centimeters. The baby's ready. And you have a sort of quite a great break here because, or not everyone, including myself, never had a break here, but I heard it's, I also had many clients having a great break here where it's like, the uterus just needs some rest and mama just needs some rest and everything is quiet. There's nothing happening, just maybe small contractions. And there's this peace and everyone is breathing and there's this transition into something. So it's sort of this like ultimate calm, but also there's building up some like powerful strength, and very often at this point the adrenaline comes in and makes the mother quite awake. And because before, oxytocin and endorphins and it has all of these hormones that creates relaxation, that creates like this birthing bubble feeling where the mother almost gets into a trance and she's just somewhere in the birth land. But when this happens and the baby is here and the fetal ejection reflex comes, the adrenaline comes in to wake up the mother and the baby. Because after all, we are mammals, and when the time is ready for baby to be born, we need to be awake and present to receive our baby. Plus, the uterus needs a lot of power to push the baby out. Like, it needs power. And all this time, the fundus have been building, so it's like quite like thick, and it's ready, and it's like after this transitional break, the mother starts like breathing. She starts like feeling some pushing on the end of the contractions. And then that's when us birth workers, we're so happy. We're just like, yes. Now it's like, woohoo, yeah, next level. And we then there's the fetal ejection contractions. They're strong. They push the baby out, not that easily, but for some very easily. And the baby comes out with the back of the head, comes out like here. Whoop. And now we know that the pelvic outlet is like this, an oval in this direction, and the shoulders stick out on each side. So now the baby comes out here, and they do like a small turn, and then maybe you have one contraction, the head is born, and then the head is outside for one contraction, and the next contraction the baby rotates like here, and the shoulders can fit through the lower key, the pelvic outlet. So, and then the baby comes out. Woohoo! And it's born. And then it's of course very important to be skin to skin with the mother and smell her and be at the breast and everything. And what happens now is that, I mean, the placenta, which we're growing the baby inside the uterus, it's still in. I mean, it's still in the uterus, and the umbilical cord is hanging out to the baby here. And the baby receives all that blood that retains in the placenta, which is like almost 50% of the baby's blood. And the placenta is pulsating the blood into the baby, and actually it's like takes 2-3 minutes up to 2 hours for this process to happen. And the blood goes a little bit back and forth, and it's just the baby and the placenta is like regulating like the perfect amount for the baby to receive. So when the umbilical cord has stopped pulsating, or that doesn't, then you can cut it. It's not like this, red and blue. Then it's white like here. And it doesn't pulsate, and it's completely like a rubber hose. And then you can cut and clamp it. But when the placenta is still in, the uterus. And if we have been good to the mother during the birth, and she has been left in peace, she has felt secure, she felt loved, she didn't stress, and she was good at rehydrating herself, like drinking different stuff, juice, water. She was good at eating different things during labor. The uterus will not be exhausted after a labor, even if it was like 3 hours or it was like 10 or it was 20 hours. So if we just let the uterus work as it was meant to work, and it take breaks when it needs to, and we drink, we eat, we rest, we're in the water, we're moving around, we're listening to our bodies, then the uterus is not tired after birth. And when the baby is born, the uterus continue to contract because all the blood vessels that are here is connected to the uterine wall, and they need to shut themselves or close themselves together, or else there will be lots of bleeding, obviously, because there's lots of blood supply from the mother going to the placenta. So we have to close all of this just open, and the contractions of the uterus helps to close these things, gives message to the different arteries to close themselves. And while this process, when it's ready and closing and the contractions are still happening, the uterus is shrinking and at the same time shredding the placenta from the uterine wall. And when it's ready, it sort of just slides out, and it's sort of laying in the uterus. You can just feel sort of like it's laying on the tailbone. So you have the mother to sit up, maybe squatting, or just have a few small pushes, like just maybe coughing, like and it just like slides out. And if the uterus gets to be unbothered in this, and we just give it the time it needs to pulsate ready, and we have fed the uterus during the whole birth, it's not exhausted, we let it do its job, we let it contract, we let the placenta shred from the wall, I mean, there will be minimal of bleeding after birth. So the placenta, it comes out, and you can choose to have the umbilical cord staying on the baby and attached to the placenta like in the lotus birth, or you can have a partly lotus birth where you just keep it for a few hours and then you cut it, or you just cut it when it's ready pulsating, and the baby is then a small human being by itself. And the placenta, you can encapsulate it or dig it under a tree or do something other holy ceremony with it, which is such a great thing. So this was a completely normal birth. So healthy, normal mother. She understands she's in labor. The baby's in a good position. And the uterus is ready. And contractions are strong and good. Mother is unobserved and undisturbed. And she's giving birth to a baby, which is just rotates out, and everything is simple. it's not always super simple. There could be other things happening, which is not dangerous, but which can stall the birth. And these things we're going to talk about a little bit also now. So let's see. So let's see that you have been giving birth for some hours. And let's go through a couple of scenarios. So let's say you get to 6 centimeters dilation, which you probably would exactly know because you wouldn't probably do internal exams unless you're in the hospital and you want your midwife to do internal exams, which is completely up to you. But let's say you get to around 6 centimeters dilation and something just doesn't move forward. It's like you're having contractions, and there can be strong, good contractions, and just nothing's happening. Or it could be that the contractions just space out, get weaker, and doesn't really get anywhere with dilation. Or it could be that you get strong contractions, but you have so much pain on one side and nothing seems to happen. And all of these things, there can be different reasons. One reason can be that the baby is not in a very good position. So it could be that the head is a little bit tilted to one side, and then it takes more effort to get through down the pelvis, because the baby needs to do more work, to rotate, and maybe you feel more pain. It could also be that the baby's head is not flexed like this, with the chin tucked to the chest, which we like the baby to be. Some babies just have their head like straight down like this, and that we call a brow presentation. And then you see, like, when the baby's head, now there were so many pelvises here. When the baby's head is flexed like this, the diameter of what going through is very small. If the head is not flexed but like this, you see what's going to pass through the pelvis is a lot bigger. And then there are some babies that have a deflexed head like this, and we call them posterior babies, and we call them very often stargazers, and they needs to come with their face through. So the flexed head, which we call vertex, here is, of course, easier way out. And some of the ones that are flexed are still tilted like this. So you see that the sutures of the head, if it comes like straight down, you have the top of the head, the occiput, which is here, comes out through the pelvis. If you have a brow presentation, you have the whole head coming out, and you could feel both of the fontanelles of the baby if the midwife would do an internal exam. And if you had a posterior baby, you would feel just the front fontanelle, and you would also feel some things from the face. And if you had a vertex, but you had a little bit tilted baby, which we call asynclitic, the midwife would feel that this sutures and the fontanelles on the head would be not in the middle, but it would be off like this. And lots of these things, if there's an asynclitic head, a little bit tilted to one side, we can do different exercises to make the baby engage better. So one of the things that we would recommend doing is the Walters exercise, which is where we have the woman laying on a bed. So she lays on the bed like here. And then she has, obviously, a big... and we put something under here, and the legs are just hanging down from the bed. And when we do this, the baby, which is maybe not want to be engaging, we sort of open the pelvis. So the pelvis is forward like this. When we do this, we open the pelvis, and the baby could easier fit, instead of the baby not fitting so well. We open and the baby can easier fit in. And it's all very uncomfortable, but most mamas are quite motivated to do it. And if you manage to do it like 3 contractions in a row, very often you see a better progress of the baby engaging better into the pelvis. And when the mother gets back up, we do I put the rebozo, which is like a cloth, around her pelvis, and she's standing, and I'm like jiggling the pelvis. And by jiggling the pelvis, it's like jiggling the baby better into the pelvis. So if the baby was a little off, the jiggling could like help the baby get this a little bit better in. So we could do the jiggling up, standing upright, jiggled with the rebozo, or just grabbing the mother bum or buttocks or whatever you call, and or hips, and just jiggle, jiggle, jiggle. And or else the mother could also be in if the baby, sometimes the baby goes all the way down, and then there's like the contractions just keep on coming, but there's like not so much happening, and the mother is she's like tired, and there are like sometimes there's a little piece of the cervix that's like stuck, or it hasn't dilated like the rest of the cervix, and it's like stuck in between the head and the pubis here. And then sometimes this sort of piece of the cervix, which we call the cervical lip, then maybe is like getting a little swollen, which makes it more difficult for the baby to rotate completely and be ready to be born. So it could be in this situation, or the baby maybe sometimes have their hands like up here, either by the chin or up by the head. And if we have one of these, we call it a nuchal hand. If we suspect a nuchal hand, or a hand by the chin, or a cervical lip, it's perfect to have the mother go into like a forward leaning inversion, like the spinning babies, which is like, it's an exaggerated knee chest position where she has her knees on something high, and then she leans over on her elbows and has her bum in the air. Or if she gets dizzy, just be on the ground in a normal knee chest position. And by being in this knee chest position, she manages then to, like, the baby gets a little bit up again, not so much, but a little bit, just a little bit back up from the pelvis, maybe enough to like relieve the pressure on the cervical lip, or just maybe a little bit back up so the hand sort of comes back out from the cervix. And by when the woman is in the knee chest, I could take the rebozo around the bum and just jiggle, and then jiggle the baby a little bit out from the cervix. And when she gets back up, maybe just it just slips through without the hand or the cervical lip had no pressure, so it's relieved and the head can rotate, finish, and the baby can be born. So sometimes the uterus gets super tired. And this is especially, I experience, like, if the mother has not been so good at like eating and drinking. So she just labors and labors and labors, and she's not eating and drinking, and the uterus gets tired and she gets dehydrated, and she's not nourished, and she just gets so tired, and the uterus is like, it's contracting, but it's not contracting effectively. So this is where you should like calm the mother, get her relaxed, maybe have some relaxing herbs or a relaxing herbal tea, something to calm her. Maybe sit in like a sitz bath or foot bath, which is like really warm. Wrap a towel around her so she gets like her fluids going. Drink water or juice, something with sugar in it. Maybe honey, eat some banana, have like nutrition, like being rehydrated, being like eating, flushing out the lactic acid from the uterus, just calming her, finding like a great position in bed, like support her with pillows so she gets some rest, and create this oxytocin building environment where she feels safe and she feels calm, and when the uterus gets some nutrition, gets some more fluids, it usually starts contracting quite effectively again later. And then sometimes there's like the contractions are like moving on. It's like everything is good. We're not suspecting the baby being in any odd position. It's just the mother is like coping contraction by contraction. It's like nothing happening, and it could definitely be like there's some emotions in the way, and we call this emotional dystocia, and it's very often happening. It's like she has some fears, she has some thoughts, she has unresolved matters that she needs to address, and she's afraid, she has anxiety, there's something with the partner, something trauma from past life, previous births, things that comes up when she's in this extreme birthing situation. And then it's important that as birth workers that we go in and we can help her address these emotions if she's in a place where she feels like she's receptive to to addressing these things, and make her feel safe, make her feel loved, make her feel understood, and again that she's warm, safe, drinking, eating, all of these things. And suddenly labors moves along when she has talked about some things that she felt anxious about, or she was afraid, or she was just uncertain, or maybe she was just not ready. Some women get to the pushing phase and they're just not completely ready to push the baby out, and just give them some time, and then suddenly they're ready and the baby comes. So that's some variations of normal, and all of these variations usually are resolved with different changing of positions, with being in water, while being heard and being allowed to move freely around. And as birth workers, we leave the mother undisturbed, but we have a small eye and ear on what's happening, and what's going on, and we listen with our intuition, and usually we can snap up if there is something abnormal that would need attention. So I hope you found this small lecture that you found the small lecture useful, and I am happy to see you, and I hope that you got some more understanding of normal physiologic birth and how our pelvis and baby work together to be born. And it's quite an amazing thing. And yeah, I hope to see you all soon. Bye.